Matthew Holt, back with another THCB Spotlight. And today we are talking about the world of the CDC and infrastructure, something that we probably may remember from a while back. There was a pandemic and we talked a bit about it then. Anyway, I have with me Craig Behm. He is the CEO of Crisp Shared Services, which we're going to call CSS for now, and Brittany Matero, who is a partner and SVP at Innsena. Afternoon, morning to both of you. Let's start with the news, which is that you're part of a consortium led by CRISP, which has just got a $255 million award to rebuild the infrastructure for the CDC, the data infrastructure for the CDC, just awarded last week. So that sounds like a fairly big deal. This is a 5-year program that you guys are going to be working on. But Craig, I'm going to start with you. And the question is actually not about the award. The question is about, we heard during the pandemic, there are a lot of problems reporting data into the CDC. There's a lot of criticism of what the CDC did during the pandemic, and whether it was aware of what was going on out there. Can you kind of, give a state of play of how does the CDC collect data now from various public health departments? Where are the issues? Where are the problems? What's the sort of state of play now?
Sure. Yeah. And thank you so much for having me. First, just a very minor correction. It's a huge grant. It's very important. CRISP is one part of it, and Innsena is supporting us. It's actually kind of 3 national partners. It's the Association of State and Territorial Health Officers, the National Network of Public Health Institutes, and the Public Health Accreditation Board. And those 3 national partners have 3 implementation centers, of which we are one. So we intend to do a lot of really important work, but not all the really important.
Okay, so you're not going to keep all $255 million and go.
We're going to do our best.
Okay. All right.
It's a really important investment, and so to get back to your question, kind of the reason it requires 3 national partners plus 3 implementation centers is that the world of interoperability is a complicated one, and the world of interoperability between the public health agencies and the CDC is an even more complicated one. And so today you have all sorts of different reporting pathways, whether they're person level or aggregate. You have all sorts of different data use agreements that govern that data. You have different registries and standards and kind of databases and methodologies, and it varies by jurisdiction. And so what we're really trying to do is think through what's a good way to standardize, streamline, and create kind of best of breed interoperability that honors all the existing jurisdictions, all the rights, all the data use, and gets the CDC better, more actionable data. So it's going to be a lot of work.
And then perhaps one of you could pick up that a bit on, we heard a fair amount about hospitals reporting in. There was intent, I know, about the US Digital Service to create a new way for hospitals to report in. CMS got involved. It was mostly during the pandemic. Obviously, people were then looking particularly at COVID numbers. But what is normally being reported in? What's the state of play now in terms of what the CDC is gathering? Obviously, there is an incredible amount of health data being moved around. As I know, Brittany, you're in the world of implementations of regional health exchanges and CHINs and QHINs or whatever the hell they keep on calling themselves now. But how much of that normally ends up at the CDC, and what are they using it for?
Yeah, I mean, I think there is a lot of data, right, that's going up. And when we talk about data, we are talking about de-identified, mostly aggregated, right? So the data is lab data, it's syndromic surveillance data, there's immunization data, there's hospital data, there's a lot of data out there. And when you think about typically your public health departments and what they are, sending up to the CDC, they are sending out all of those things, right? Sending it up so that the CDC can think about population health. How do we get in front of disease surveillance? How do we get in front of those threats? How do we make sure that we really have healthy populations, healthy states, healthy communities? So it's a lot of data. Again, de-identified data that's going up and is helping to inform, what are our strategies? How are we leaning in? Where are we making investments? What are we doing? How are we shaping our programs? How are we thinking about workforce? How are we meeting the needs of our people?
So there's a lot of different things going on.
A lot of different data, a lot of different things.
Obviously, there was a fair amount of criticism of the CDC during the pandemic for, either not being ahead of the data, not collecting the right data, and also not giving out the right information. CDC leadership has changed obviously since then, both for the change in administration with Mandy Cohen coming in. Before the award of this new pretty substantial infrastructure grant, what if you were there, what would you have said were the problems that this grant is this new program is supposed to fix?
Yeah, I think maybe we should start with like the immense complexity of what like public health workers do every day.
Sure.
And kind of how it's evolved over time, right? So if you're a public health department for an average size state, you probably have 200 different IT systems, each funded with separate authority, collecting different data. And your epidemiologists are doing certain things, different environmental health folks are doing different things, and they're all working in kind of what's always been siloed platforms. And so now when, for example, the CDC says, well, I need to know of long-term population trends, or I need to understand the prevalence of certain diseases or conditions over time, it's really, really difficult, even at the jurisdiction level, for them to gather that data, to link it, and then share it. And so a lot of what we're seeing with the CDC, I think, is that the states are so busy and doing so much really important, impactful work on the ground that they can't then also figure out a good methodology to share the data upward. And that's not even touching on the kind of the policy complexity of all these things. And so what I think a lot of this grant will do is help give the local resources, guidance, tools, information, best practices, so that they can link the data, become more interoperable, and then share it upward to the CDC.
And I think too, just adding on to that, when we talk about this work, we are talking about states, state health departments, tribal health departments, local health departments, and territorial health departments, right? So it is very broad, the number of systems, and not just siloed electronic systems, but, people that are still using Excel spreadsheets, right? They're still using manual ways to collect and report data. So, a lot of complexity here that we're talking about. And, and this is exciting because this is really helping to bridge the gap. And we're also talking about a space that is, traditionally been underfunded, right? Like public health, really, they had small pieces of high tech when high tech funds were infused, but they did not have a lot of it. So this is a really concentrated effort to, really bring real-time data into their hands, help them to move to electronic workflows, help to reduce that administrative burden that they're facing. And we didn't mention this, but just to throw it out there too, there's going to be a fourth implementation center that is specifically for tribal health and agencies that are tribal serving organizations as well. So we will have 4 implementation centers helping to coordinate and get this off the ground.
So we'll get into what you're going to do in a second, but I'm still trying to sort of capture a little bit from you the bit about what you've been brought in to fix, as it were. And I think, if you wanted to take big picture of the Biden administration for however long it lasts at the moment, one of the things they said, right, is that there's been historic underfunding of infrastructure as a whole, and we're going to do this in all different places. Now, obviously, we did have during the Obama administration and going into the Trump administration certainly the Obama administration, a huge amount of spending on private sector electronic medical record infrastructure, which those of us have been dealing with for many years, and a lot of that was to just get those people really get the private sector kind of the ground zero. So it was creating electronic data which could be shared, and then the last few years, of course, with TEFCA and ONC has been sort of continued explorations, and I would say largely big improvements and maybe even success in getting that data shared between private sector actors, usually on a one-to-one basis around treatment and care, which is identified data. Now you're talking here about de-identified data for spotting trends. Obviously, 2 big trends that needed to get spotted in recent years were COVID related and opioids related. I mean, 2 very big initiatives around issues and other drug use and other stuff as well. Where have we been, missing stuff? Where is CDC, do you think, at this stage if they were looking around going, we know there are things that we wanted to know sooner, better, faster, so we could get ahead of them. I mean, how much is this inspired by what happened in the pandemic? How much of this is that, there are things that we don't even know about, which might be to do with, who knows, tuberculosis outbreaks or something that, that are sort of under the radar, or I don't know, antibiotic overuse. I don't know what the category could be. Where do you think that if you were, Mandy Cohen running the CDC and wanting to give me the dashboard that's up to date, that's got all this stuff done, what do they not know that they want to know?
Well, I can start, Craig.
It'll be a long list. Go ahead.
There's a long list.
I'm assuming the next question is going to be, by the way, how are you going to fix that list? But go on.
Yeah, well, and really it rolls right into our work, right? Like if you take a look at the CDC's public health data strategy, they're focused on a few, very concentrated things. Joining TEFCA, right? So how do we think about the exchange of data that needs to take place? Expanding and improving electronic case reporting, expanding the emergency department and syndromic surveillance data, right? Standards-based data exchange, and accelerating the use of FHIR. And I do think that is like really touching the very tip of it. There's so much, but they have prioritized, those things as a starting point. And I think it's a good starting point. You have to start somewhere, right? Like a bite of the elephant, not the whole elephant.
Right. And so maybe like as an example, and I'm not a clinician or a public health expert, so this is going to be a dangerous process, but let's say the CDC
has one during the RFP process, I'm sure
that. we bring really smart people like Innsena.
You had a friend, right? Okay.
But so if you have, let's say the CDC is monitoring respiratory health for children, something that we all want our kids to breathe healthy. And so maybe a jurisdiction has an asthma program to make sure no child goes to the emergency department with an asthma attack. Kind of traditionally in a lot of places, partially because pediatricians are very under-resourced, local health departments are very under-resourced, and hospitals are very busy places. In order to understand that a child went to the ED with an asthma attack and then is perhaps eligible for some type of intervention, you're linking a paper record maybe from the doctor's office with a different medical record number from the hospital, which then has to get submitted to the local health department, which then has to be reviewed and tagged, and then shared with the state health department or state Medicaid program. And each of these steps requires multiple people and multiple days. And I think I can't understand what the CDC necessarily was thinking as they were writing this program, but I think technologists know this data is out there. It all exists. There have been a lot of investments in the private sector and public sector to make the technology interoperable. And so to have a health department understand immediately if a child who's eligible for a program goes to the emergency department with asthma, and then to monitor and measure the efficacy of different interventions, like that can happen today if you have the right standards, if you put in kind of all the things Brittany just mentioned with kind of FHIR-based exchange and hopefully TEFCA for different use cases. And so really, we're trying to bridge that gap between what we know is possible and what we know the different kind of federal and state agencies would like to do.
And is that more, I mean, that example you used there, Craig, is more like one way where you're actually taking there are plenty, obviously, of services for individuals done by county and state, federal health departments, if you think about the Indian Health Service and whatever else. But there's that, and then there's also which probably happens at the county or the state level, with improving communications in those jurisdictions and those offices. And then obviously there's reporting up to the CDC and getting some national trends and all the stuff that we heard about during the pandemic. For this, let's talk a bit about what you guys are actually going to do with the time and the money in the next 5 years with the money that's been allocated. Are you fixing that at the local level, or is it more about reporting up to the federal level, or is it the same thing? How should you take us a bit through how you're going to fix that problem for the kid with asthma who should be in the whatever local county program for fixing asthma for kids, as opposed to Mandy Cohen having to figure out whether bird flu is a big deal or whether it's whether it's the next Ebola, i.e. doesn't really matter, but pay attention, or whether it's the next COVID pandemic.
Yeah, so I think we're hoping it's the same thing to a large extent. So the program design is that kind of the different agencies who are able and willing to come to the table are submitting expressions of interest. And then they will work with the implementation center partners to do a full evaluation of essentially their current resources, current assets, current capabilities, and how they fit with what will be a long-term investment that aligns with the CDC's kind of data modernization initiatives. And the idea would be that kind of based on all that information gathering, based on input from subject matter experts, based on local needs and prioritization, we can provide, lessons learned, technology, financial assistance, and guidance to move them forward, maybe as more of like a maturity model than solving all their problems. And so if some of those problems are, better interoperability standards because they want to do faster case investigation, then we can help them focus on that area. If it's around data link to link, different data sets and make sure they can do better analytics at the population level, then there might be some pathways there. But ultimately, I think if we do our jobs and we listen to what the local jurisdictions would like, this will help ease the burden and get better data to the CDC faster.
So let me ask you the next one. So if essentially you're going in there and doing a sort of consultative support role for all the different groups. And there was something like this, by the way, attached, and I forget what it was called, but it was modeled after like agricultural support in the 1920s. It was something like this during the original high tech program, right, where there were centers which went and helped doctors figure out how to use EMRs and put them in and all that kind of stuff. Support. So I get the process. The question is, there was a lot of criticism that not only were public health departments underfunded, but there wasn't good national standardized technology and reporting systems. Are we going to see change in that, where we're going to have more and more public health departments on the same kind of standardized reporting systems, or are they going to have to, are we going to still have 1,000 flowers approach, or what do you want, 1,000 points of light approach, and you're going to have to work in there trying to craft a strategy that's still going to make it fairly muddled at the national level? Where do you think we end up in that? Because I know nothing about the actual infrastructure and technology being used in public health departments, but I'm sure it's not all the same, right?
I don't think we're going to fix everything in 5 years, right? But I do think that we're going to make movement towards those systems and technical standards, towards the data standardization piece. We are going to move the dial on people at the states, tribal, territorial, local public health departments, starting to implement those technologies that actually are interoperable. And they're already working on them, right? Like there are a lot of plans in place. There is a lot of work that's being done. I think the will is there and that we see this, and this is a really great time for there to come investment, and these implementation teams that can really help to support and drive those changes, and those modernization efforts.
Yeah, I mean, one of the reasons that CRISP Shared Services got involved, and the reason we're so excited, is because we do bring technology to the table, and we bring a lot of expertise in taking, maybe messy is not the most technical term for it, but kind of messy data and normalizing it, linking it, and standardizing it. And so we're coming to this with the perspective that, if you're a health department with 200 IT systems, and some are Excel, and some are Microsoft Access, and some are still converting PDFs to some other system, the best we can do is let the public health workers do their best work, and slowly over time kind of link, normalize, and kind of upcode those different registries into a common platform. And so I think hopefully we'll have some combination of letting the jurisdictions do exactly what works for them, because each is very different and has different priorities, different areas of focus, but also freeing the data so that it can be linked and used in much more standardized ways.
All right. So, Craig, let's go into the nuts and bolts of it a bit here. You mentioned there are 4 transformation centers, and you're doing one of them, correct?
Correct.
Does that mean there's another? I should have paid attention here. Is that there are another four grants that are of similar magnitude with 4 organizations helping elsewhere?
Yeah, so there were essentially 3 implementation centers created and awarded: CRISP Shared Services, Guidehouse, and Mathematica.
Right.
Each of us, just like the 3 national partners, brings something slightly different to the table. So we're in the process where we're building out standards. What's it look like to create best practices and policies around modernization? Ultimately, the goal would be that each of us will work with a state, tribal, local, territorial health department and bring both their individual lessons learned back to the larger group, and then bring kind of each of the implementation centers' expertise back out to these cohorts through learning collaboratives, different methodologies.
And then within the one center that you're both involved in, you've got CSS, Innsena, Zane Networks, and Burton Policy Consulting. Who does what within that? How did you break up that work?
Yeah,
we're
well, so
all working together.
Please don't tell me all four of you are doing exactly the same thing.
No, I do what Brittany tells me. So each of the groups, and I can't speak for the other two implementation centers, but within CRISP Shared Services, we believe very strongly in a best of breed approach. And so Innsena brings really deep public health expertise. They do a lot of kind of maturity modeling, sustainability modeling. They've worked in health agencies, so they bring a lot of those efforts. Burton has been a group that's helped us a lot on a little more deeply on the policy side. So they've aligned Medicaid with public health funding. They've looked at some unique payment models and how value-based payment programs affect essentially population health, public health programming. They also have a really kind of interesting kind of patient advocacy lens as we think through privacy, security, being good stewards of this data. And then Zane Networks has helped us a lot, both on kind of technical implementations, but also they can provide workforce training, some of the different environmental surveys. And so each group, I think, is very complementary, but also we're really excited to be working with them in this shared capacity.
And then how does it work from sort of the ground? Now, I'm sitting as a county health officer somewhere in America. This program's announced. What do I do? What happens next? How do you get involved with them? How do they get involved with you? How does stuff actually start to happen?
Yeah, the first is an expression of interest, and the details on that are still have not been released, but they are to be released soon. So if an STLT stilt wants to engage, they send in an expression of interest, and then we begin working on it. So it'll get assigned to an implementation center. That process is still being worked on. And we'll hit the ground running to start those evaluations, assessments. Where are you at to begin with, and where do we need to work together to move the dial?
And who is your collaborative working for? So in other words, if nothing happened and you weren't doing anything and nothing was being moved along, who you looking at? Who's looking at you saying, "Hang on, you're supposed to be helping, all these different counties," and where does that work? Does that come out of the CDC, or who makes sure this happens? There was a little bit of criticism during high tech. I mean, there was free money being handed out, but there was a little bit of criticism. There wasn't in some cases the oversight that should have been, and so I know that government's sensitive to that. So how do you get kept on track?
Yeah,
Yes,
so we report. Go ahead, Craig.
Well, so essentially the CDC created this grant through three partners. I mentioned them: NNPHI, FAB, and ASTO.
Yeah.
And so it's really the three of them who are working together as a steering committee, who are monitoring the grant, who are holding us accountable. But I think a little bit of this is you can see the pendulum has swung. So we're bringing a lot of expertise, a lot of oversight, a lot of deliberate reasoning to the table. And so we are building the airplane as we fly it a little bit.
Yeah, I do think one key point that you sort of touched on, high tech didn't have a lot of, it was a lot about, here's the money, what do we do right now? And the sustainability piece, right? A lot of states then, when high tech was going away, they were really struggling to think about how do we do sustainability? And part of this approach does have sustainability as a core foundational piece. So this work is not only about, the modernization and implementation of interoperable technology and standards and all of that. It's also about the sustainability piece. So how do we keep this moving? How do we keep working towards systems that, are talking to each other with that real-time data and all those pieces?
Yeah, and I think there was, as you mentioned, Brittany, part of the criticism of high tech, obviously most of the money and most of the focus went to the EMR side. You also had the health information exchange side, which at the same time kind of the technology was kind of running past the setup of the organizations. You know, and probably a lot of people would sit around and say, well, there shouldn't be health information exchanges because, you know, you've kind of got it already using the internet. Why do you have these other things? And I suspect you'll run into the same thing in the next 5 years, as you know, you have to come keep track with when people are getting off Excel spreadsheets and getting into sort of interoperable solutions for their public health reporting. You know, there'll be stuff coming up that will have to be worked into that. So having said that, we're now here. It's now 2029 or 2030. You guys have been working on this for 5 years. What does public health reporting look like? What does good look like in 5 years' time after you're done?
Wow. So maybe like highlighting that last the piece you just said, you know, the most important part of these types of programs is building a long-term investment in an infrastructure that is both innovative and can evolve. And so in 5 years, hopefully all the different databases and data sources within a public health agency will be linked and will be trackable and kind of on best possible, most modern standards. I also hope we actually have less data exchange to a large extent. You know, instead of a hospital having 20 different interfaces to their local and state and CDC and all these different groups, if they could have one interface that went to a single place that was kind of best possible standards, had high data quality, and that was useful at the point by the public health workers, different groups, I think that would be a great thing. But maybe most of all, you know, if we can get the policy framework right, if we can be aligned with TEFCA, if we can be aligned with national standards, then in 5 years, you know, maybe all sorts of new AI models and large language things will be changing the way computers talk to each other, but the foundation will be in place that moves the public health industry forward with the rest of the healthcare industry.
Yeah,
Brittany, what's your hope for 5 years?
Totally agree. And to that point, also that there are those state, you know, we still have a lot of diversity in state regulations. So having an alignment across our state regulations as well would be like, I'm excited for that day.
Yeah, I mean, I think that there's been a lot of criticism. I mean, I think during the pandemic, it obviously was heightened. There's a lot of criticism about the way that, you know, reporting in Germany was kind of instant as to what was going on in hospitals, and here we were scratching around and you know, submitting spreadsheets, and we never quite knew what was going on. We spent a lot of money. We are spending a lot of money on infrastructure in general in the US due to the various acts passed during the first couple of years of the Biden administration. You know, when they start showing up in more than ribbon cuttings and sort of, you know, agreements by people to build chip factories and, you know, build roads and what have you, and actually start to change the infrastructure in the US, will be interesting. But it's good to see that, you know, the public health is coming along with that, because I think it got a lot of criticism, and there was a lot of people, certainly on the podcast I run, the healthcare TCB gang, a lot of people were saying, you know, we should be spending all this money and we haven't spent it and we're still way behind. I mean, the Taiwanese know what happens instantly and we don't know. So, you know, I think that these are great aspirations. I think, you know, American government is complex and always has been, and, you know, presumably always will be. So I think that, you know, what we have to do is try to, you know, you're gently trying to sort of migrate the streams of workflows and of how people are behaving, and, you know, infrastructure, and getting it all together. But I think that aspiration, Craig, to get, you know, one interface that every health entity plugs into, that goes to the right places and starts sort of, you know, showing up in the right policies and workflows is really what we want. So that's great. All right, before we go, real quick, Craig and Brittany, best tell me, what do your organizations do when they're not doing this grant? So what does CSS do in its your other day jobs, Craig? Tell me a bit more about the organization, and Brittany, same thing about Innsena.
Yeah, so CSS is supporting interoperability through mostly state-based health information exchanges. We started in Maryland, where we got a lot of depth in kind of value-based payment models, the hospital rate setting programs, and have since spread to 7 states, where we essentially support nonprofit state-based HIEs to drive interoperability. So this grant's like really well aligned because each state is different. Each group needs to have their own control over data, their own prioritization of their data. But the technology is more or less the same. It can be built so it's configurable and flexible, and hopefully can drive good results at the point of care and for these different stakeholders.
And how many people are you? Give me a sense of the scale of the organization.
We're a little bit less than 200. So still relatively small shop, but doing some pretty impactful things with a lot of sensitive data flowing through us.
Excellent. And Brittany, tell me about Innsena.
Yeah, so we are a little smaller than you at almost 30 people. So we're a go-to-market consultancy specifically for the healthcare, health technology space. We work with health technology companies around expanding and growing their business into new networks and buyers and spaces. We work with health information exchanges across the nation to think about programs and policy and strategy and how that aligns with what's happening across the nation and federally. And then we work on federal initiatives that are near and dear to our heart that we're passionate about. So we work a lot in the Medicaid space, the public health space, really thinking about how do we pair technology, how do we think about funding, how do we think about policy and regulation, how do we tie it all together, and really how do we go upstream so that we're not doing exactly what we did during the pandemic, which was, try to figure it out and run behind with all of our hair on fire. But how do we truly get in front of it? How do we be innovative? How do we change the dial when it comes to healthcare across the United States?
And then the other important thing is that your president, Ms. McDavitt, tends to throw the odd party and has the health tech talk show, which I think every Friday at 4:30 Eastern. Am I right in timing?
That's right, 4:30 Eastern. Yeah, yeah. We believe in the power of people.
All very good. All good fun. All right. Craig, Brittany, thanks for your time. Really interested to find out what you're doing, and good luck with the next 5 years. I'll come back. We'll set a date for 2030 to figure out what happened.
Thank you. Pleasure being with you
Great.
today.
Thank you so much.
Bye now.